So I am very glad here and wish to welcome all of you. And also want to be able to put this up for like a dynamic conversation, especially towards the end, or even earlier to help frame some questions, because some of what I'll be speaking about is particular to the United States, as we have different laws and we also have different ways of funding the health system. And so I'm happy to engage in direct conversation, also have questions live. So I'm an emergency physician, and I am co-founder of an organization called AFFIRM. And we're here to speak about what we as healthcare providers can do to prevent gun violence and not just treat gunshot wounds. And we come from this from a position of accountability to our communities. We do truly have an oath to heal, but also an accountability that's ethical, that's legal, to protect our patients, their families, and our communities. And we also are very deeply embedded in this problem. We see how deep this problem runs in our communities, unlike many of the other stakeholders in this space, because we see not just what happens upstream, but also the ripple effects that happen downstream. And we're also there in the moment when we're to effective resuscitations. I am a CEO of this nonprofit. I'm a volunteer CEO. I have no financial disclosures. I'm also a practicing emergency physician in Western Massachusetts and Southern Vermont in the United States. So this is a headline from the New York Times in 2017, which is like what we saw in 2013, and we see pretty much every time there's a catastrophic event involving mass shooting in the United States, there's a sense that what can we do about this? There's an incredible frustration. And this always descends into an impasse of gun rights versus gun control. This is the paradigm of how we in the United States view the problem of firearm injury and violence. And the United States has a Second Amendment, so it's a constitutional right to own and carry firearms. And we know that the answer to the problem of firearm injuries, misuse, and neglect in this country is not to destroy gun rights, but it's also not to allow every person to have a firearm, because some people aren't safe. And when people who are not safe have access to firearms, then none of us are safe. And besides, the United States of firearms, there are approximately 420 to 450 million firearms in private ownership in the United States. And you have to think about the population when you think about public health methods. And we are not New Zealand or Australia, other countries that can simply decide they're going to ban and seize certain firearms. You've seen our last election, probably. And you see also the groups of individuals that have been active in resisting what they perceive as government overreach. So for us to go out as a country and try to take firearms from groups like this will lead to lots and lots of problems and is unpalatable. So seizing a firearm is not something that we believe is an option or viable. And therefore we don't think about it and the organization. Generally, depending where you are, gun ownership in this country is 30 to 40%. Rural areas have higher ownership, urban areas have smaller. There were about 20 million new gun sales last year during the COVID pandemic, and 8.4 million new gun owners in 2020 during the pandemic and the periods of civil strife in the country. So that's new gun owners, people who have never purchased firearms before. And about 40% of them were women. So we recognize that since politics is not going to help us solve this problem, we have to think about it in the way that we approach all problems in medicine, which is think about solutions. And we think that the axis is actually diametrically opposed to the rights versus control issue. And we can begin creating solutions together when we have a trusting relationship. And I have to digress for a second and give you a little bit of history of distrust in this country. Because there was a time when firearms particular groups like the NRA and the manufacturers and trade associations for firearm groups worked together on creating gun policies, and from 1968 to 1993. And the majority of these legislative initiatives were intended to establish who was qualified and who wasn't qualified to own a firearm. But then they started to add in some additional pieces of legislation to restrict the access, to restrict the types of firearms. There was consensus and collaboration on people who were disqualified. And these are people who had had previous demonstrated behaviors that are illegal or criminal or dangerous. These are also known as static and dynamic risk factors in health parlance. It's a pretty short list of people who are disqualified from owning firearms in this country. And again, it's based mostly on prior criminal activity. The intention of this is to prevent access of firearms by disqualified individuals. And most people can get behind that. And the firearm industry did as well. There is the concern that when the firearms stakeholder groups were negotiating at the legislative table, that they gave an inch and a mile was taken. And what started to happen was a shift from criminal behaviors as a means for disqualification to restricting the device itself, to which all of us in America have a constitutional right. And there are different cultures that own firearms in this country, some of which are political and some which are not. But it becomes a pretty testy issue, as you know. What happened here when we started to restrict the device as opposed to behaviors is it equates safety with device restriction. And that suggests that the device itself is unsafe and implies that those with the device make all of us unsafe and in some way criminalizes the handler in certain views. So in short, this interpretation of restricting access to firearms based on policies to make it more difficult or unable to purchase certain types of firearms or the timeline for that is what we perceive as safety. And so what happens is that when you have an interpretation of safety that's based on the restriction or absence of firearms, then you have the one culture of America who believes that we should just have no firearms or none of this certain type of firearms. And this is a quote from Stephen King, who is a novelist who writes about horror and murder and violence. The other side is are a lot of people who like me live in rural America and have a family history of firearm use. This is a country singer. My first rifle was .243 that was handed down through his family. They taught me how to shoot with a steady hand. I guess that's something you don't understand. And this is an idea that's held by a lot of people that guns don't kill people, but people kill people. Again, they're talking about behaviors and not the device. And there is umbrage taken when people who own firearms feel that they're judged by legal gun owners by the unlawful use of firearms in criminal hands. I'm not a criminal. I should not have any restrictions to when or where or why I buy a firearm, how many, and so forth. And so this leads to polarity in America. And you have two camps of gun lovers or pro-gun, or gun haters or anti-gun. And it always descends into this battleground. And this really is a non-starter, right? If you're on complete opposite extremes, it's really hard for you to get around. You hate guns or you love them. And so we descend into this catastrophe in America that we are dealing with now. There are many groups right now that are seeking to normalize a conversation about gun policy. And it's really important for us to talk about firearms and like firearm policy and have a good construct. But we, in this country, cannot even talk about face masks in the time of a pandemic. So it seems like we're trying to have the same conversation over again, maybe with more people. And I certainly think it's great to try this. But we understand that policy is not going to solve all this problem of a complex public health issue. And so what we do in healthcare is we take an alternate path. And we are truly accountable. And what we want creating is a platform where those of us who deal with this problem on a daily basis can work with everyone else in this space to identify opportunities for solutions and to create change. And in the United States, we have this concept of the healthcare safety network, which are emergency rooms. And our health system is not compensated at a national level. So there's a lot of private payers, and a lot of people can't access healthcare because of financial restrictions. However, there is a law in this country that requires any person showing up to an emergency department has to be seen and treated for their health emergency. So what that means is we see everybody that comes into this country, or everyone here who comes to this country who has a health emergency. And that's really important because we when people don't have access to healthcare and have a health problem, they have bad outcomes. And so we count, so health people are brought to the ERs by every type of other stakeholder in society: police, EMS, law enforcement, fire departments, nurses, and so forth. And this is important, right? But it also means that we see all of the trauma, we see all the risk, we see all of the negative outcomes that happen in a community. And so we have consensus on a number of things. One is that we believe that we can work together and create health-based solutions and build systems of care to address this problem. But we also start from by wiping the slate clean a little bit and focusing on the behaviors as opposed to the device. Because what we know that how a gun can be used depends on how it's built, but how it will be used depends on the handler. And around this, we can gain consensus. We also have a lot of tools in our toolbox that have been successful in the past. The public health approach to anything has been successful in treating epidemics and motor vehicle accidents and HIV and so forth. And it's a fairly simple approach. You define the problem within the community. You identify who's at risk and why, who's protected and why, and then you develop some strategies and you test them, and then you scale what works. It's really simple. We've done it before. It works universally. We also know that violence does not develop in a vacuum. We think about gunshot wounds primarily, but there are hundreds of risk factors for violence, some of which can be changed and some of which can't. And all of us have these risk factors. And at a certain point, these risk factors escalate. And if unchecked and if the right context develops, then the gunshot wound happens. And after that, there are all sorts of consequences, ripple effects that then can actually feed back to the risk factors for other people. But we know if we intervene on the risk factor expression, like we intervene on risk factors for every other disease or health condition, we can prevent the negative health outcome. It's those truths that we accept and have practiced in medicine. And we also know that we have to think upstream. And there are established evidence-based ideas and pathways towards violent conduct. And if we pull the levers for dynamic risk factors, then we know that people will progress. And if we add protective factors, then we can keep people away from moments of harm. And the idea is for us to identify where people are on this trajectory of risk and actually help them. Because we need to engage all of us in the community. And just as these groups will bring patients to us in the emergency department, where we then deal with the trauma, we can count on these people in the communities to have their eyes or ears out, one, to help identify who's at risk, bring them to us to healthcare, but also what interventions can they do that are health-based, that we can develop together that might change the social norms around this topic and also start interventions in the field. And this is certainly not about trying to predict who is going to do something bad. It's as impossible and inaccurate. It's been demonstrated repeatedly in prospective studies that we cannot predict who's going to complete an act of violence. It's really about managing risk, identifying it, and then optimizing safety and minimizing risk at every opportunity. The goal here is to help the person, not just the person who's a potential perpetrator of violence, who themselves come from a background of risk factors and adverse childhood experiences and so forth, but also the potential targets, right? We need to think about both everybody involved in this problem. And we have to create individualized interventions for everyone who is at risk. And we have to identify what are the risk factors, can we treat them, let's treat them, and what protective factors can we leverage to make everything safer. And so we recognize that violence prevention is a team sport. And for this reason, we're here. And I'm very glad to be here to talk with you because in my experience in emergency medicine and also now in education, the links between the collaborations between law enforcement, pre-hospital, and emergency services have not been fully developed. And I think there's lots of opportunities for us to find ways to cooperate. And I'm going to talk to you next about one modality that we're piloting here with some success, and we hope to share. We recognize that all of us have a role to play. and that what we're trying to do is change social norms around the topic of violence, and in particular in the States, firearm violence. And we come from a really easy vantage point in this perspective medicine because our norm is just care, and care is a positive social norm. So this is not so much about care. This is not so much about restrictions or snitching or any negative connotation. This is about caring for everybody. The question is, how and when do we do this? And to kind of think of those opportunities, right? Because these are big words and nice ideas, but how do you actually make that practical in a way that's potentially scalable? And the answer to that is really in health systems. But there's one other paradigm I need to discuss with you, which is kind of how we practice in medicine. So in ERs, because we see all of the negative health consequences, we know it's happening in a community. And when we deal with trauma, it's hard for us, especially repeated trauma. And when it's also hard for the communities. And these are teachable moments. And my experience over the past 20 years is that people do not want to talk about trauma unless they have to. And individuals' attentions to the topic will be aroused and will be present when we're experiencing that problem directly. And that's the time we can actually start to receive information. And so we know when this happens in healthcare. So health systems are an excellent place to identify in a community when it could be ready to receive information and work towards collaboration. And we have to think a little bit, we're also trying to remodel within medicine how we think about this problem, because up until recently, everything we were taught in medical school, how I was trained in medical school and residency, and with respect to firearm injuries, that my job was to take care of somebody who was shot, resuscitate them, and then move them on, right? And that's kind of what we count from an epidemiological perspective in the States. We count bullet holes, gunshot wounds. We talk people who are dead and people who are injured by that. And we don't do a great job of it, but that's how we think about the problem. But actually working in the field, we know that there's a lot more that hasn't been measured, right? We're not measuring the rehabilitation, the costs associated with that, and all the ripple effects that come from it. Like, what's it like to have a colostomy and be in a wheelchair for the rest of your life after a gunshot wound to the back? These are things, these are health costs that we actually are not measuring effectively in this country. We also know that we're not measuring secondary victims, because every shooting has collateral damage. Witnesses, family members, children, spouses, and these individuals will suffer discrete health conditions, both physical and mental, as a result of that trauma. And I can tell stories about, because I live in a small community, I can tell stories of people who've witnessed gunshot wounds at close range where family members have died, and weeks later saw that person in the emergency room on an overdose, right? Who is responding to their trauma. And I know full well that those people are victims of firearm of gun violence in this country, but they're not being counted that way. We also know there's a negative effect on healthcare workers. Trauma is heavy, and it contributes to burnout quite a lot. I know a pediatric surgeon who ended up 2 years ago retiring from her practice because she could not take the trauma of gunshot wounds repeatedly in working in the city of Chicago. My staff, nurses, paramedics, we are deeply traumatized by taking care of these patients and then giving the bad news to the family. And this actually is kind of where a lot of this idea of reframing comes from. We also know that violence has infectious qualities, where it'll cause emulative behavior or retaliations, right? So it's not just one gunshot wound, there's multiple gunshot wounds that come from one over time. And so really the paradigm is this big mess, right? It's really complicated. And it seems like, what can we do to fix this thing? Health-based approaches potentially can work, and we can do that. So what we've landed on at AFFIRM is this idea of reframe, which is about reframing the issue and the conversation. And we realize that, all right, so public health is a term, right? And I'm trained in medicine, but I wasn't trained in public health. And it took me several years to understand what this is. So we realized that we need to demonstrate what the public health approach to firearm injury prevention means. And that means we can convene and share knowledge and experiences. We can develop trust with our community and a shared sense of purpose. We can get insights from each other, and we can drive education and research from the community. Because we know that firearm injuries impact more than just one person. They affect everybody in the community, and it affects every sector of society. So when in your community you have a firearm injury or a shooting or a suicide, there are ripple effects that are poorly mapped, but everyone's involved. And so what we do with Reframe is we share what we know, what we think, and then what we want to do. And we do this based on education, evidence education, our narratives, and our accountability in the roles that we have as healthcare providers. And by doing so, by bringing these troops together, everyone involved in the safety net, we can incubate ideas with new people. We can translate some really difficult topics to each other, because in those communities, we learn how to speak language about the topic, about firearms, about harms, about risk that we wouldn't know from the outside. We connect people to each other, but also to national networks. And through that, we can innovate some new solutions and facilitate change. So what we're trying to do with this Reframe concept that I'm going to run you through in just a minute is to create a customizable platform for community engagement with health systems, healthcare providers, and the other service operators in the area to have opportunities to engage on this topic and understand opportunities for solution, but also to make it scalable so that all communities can engage in this. Secondarily, we're trying to measure the impact of this. Does this impact benefit on resilience? We have in healthcare and also in law enforcement and pre-hospital services, we've all gone through the critical incident stress debriefings with variable effect. Can this community-wide debriefing improve the resilience of medical staff? Can we increase the impact of education? Can people change can they learn more effectively in this process about what they can do? And can we try to change the social norms around this topic, where it's okay to talk about hardship, where it's okay to talk about someone's access to a firearm if you're worried about that? And these are all work that's ongoing about what we can do. Will these platforms work? And I'm going to give you an example of a project. And this is my community of in Berkshire County, Western Massachusetts. We conducted this pilot back in early winter of 2019. And in my community, we have a significant problem of suicide, firearm suicide in particular. And as in the ER, we see everything, and we're all connected to each other by various degrees of separation. And we had a series of very traumatizing injuries and deaths due to firearms in my community. My medical staff had been to one too many debriefings and wanted to do something more. And because we knew the families and knew the victims of these events, we thought that we could do something together to collaborate on the education. And so this was that teachable moment, because we'd had some cases and it was present in the minds of the medical staff, but also present in the mind of the community. What we did is we convened an event and we brought together the entire Berkshire community that would show up. We brought the medical center, the Massachusetts Coalition for Suicide Prevention, and the Massachusetts Medical Society. That was a local group. And through AFFIRM, which is a network organization, a number of other professional medical organizations, the College of Emergency Physicians, American Association of Pediatrics, College of Surgeons, Emergency Nurses Association, so on. We're able to bring the expertise and their members who are in the community to participate in the event. And because we truly do practice a nonpartisan approach, the Trade Association for Firearm Manufacturers in this country also participated with us, the National Shooting Sports Foundation. And so how this worked is we recognized, okay, there are these cases. We announced, okay, in our community, we're going to talk about suicide prevention because it's a problem. And suicide is not something people want to talk about, but people showed up, 90 people showed up on a snowy Monday night to talk about suicide prevention in a small community. And it starts with why we're here. We recognize that there's a problem and how it exists in the community. The second step of how we reframe is to set some ground rules, decorum and communication. We have to create a safe space for us to converse with each other, understanding that there are people who have been traumatized in that community, so they may be triggered. We also have to make it safe by making it apolitical and making it clear that we're not talking about policy. And they're going to say focus on the problems that we're experiencing only. And because we create this safe space and we start with a position of our own vulnerability, it's easier for people to engage with us. And so once you set the ground rules and know why you're there, we start with a story and a moderated discussion after that. And this is the use of narrative. And it's based on a precedent that we use commonly in healthcare, which is the Morbidity and Mortality Medical Conference. And how this works is we have them every week in education centers, sometimes every month, where we talk about cases that didn't work out or had a bad health outcome. And then we walk it back every step of the way to see, well, what could we have done differently to not have that negative outcome, to have a better outcome? And so what we did is we conducted a couple of stories here, and we used stories from the communities that we knew ourselves or that were reported by the persons who experienced them, or they were fully de-identified. Understand we have to mind confidentiality. And so the first story that we tell is one with a bad outcome. And in this case, we start with a scene where a person in distress was talking to a friend and communicated some suicide ideation. And that friend was worried based on that call and called 911, the dispatch, which is law enforcement. And so the first touch with this person in this field is law enforcement. And then after arrival of law enforcement, then EMS is called, those are paramedics. And the paramedics get involved in the scene. And then they bring that person to the emergency department. And so we're able to tell, because we have historians' narratives with law enforcement, paramedics, and ED, we understand what was happening in that moment truly, right? And then in the ED, in this case, we talk about what we do for risk assessments in suicide and the laws surrounding that. And being in a situation where you saw the risk, but you couldn't do much to mitigate it. And ultimately, the patient had to be discharged. And then the second part of the story is the person who we were all worried about, but were unable to restrain or civilly commit, went home and harmed himself with a firearm. And so then we have the scene from the field again. And then law enforcement goes back to the scene, and the paramedics go back to the scene. It's not a recoverable injury, and the patient is pronounced dead. And so when we go through the story, and these are our stories, right? And so for us to talk about failures like that in clinical practice is hurtful. It's hurtful. We're able to see, okay, these are all the different opportunities that happened that led to this negative health outcome. Right. And so now we see, okay, this is what this whole problem looks like. It's not just this one thing, this is multiple things that go to it. This is then followed by a very brief, accessible, evidence-based education, which includes, okay, suicide, we're talking about suicide here. What is suicide in this community? And how does it compare to the region and the nation? Because and then they actually have a real lived experience of what that means. We talk about what is the pathophysiology of suicide or the nature of the problem? What are risk factors, protective factors, and what interventions exist? And this is a very brief 15-minute education. And this is followed then by the evaluation of assets. And that's where we have our partners present on what resources are available in their community, but also nationally. And once you then walk through the entire process of understanding how this true story impacted the community, and that there actually is evidence that makes it possible to avoid the outcome, we have a second discussion, which actually gives a survivor experience. So people who live through that can talk more directly about what their experiences were, but also what the opportunities that they could have seen ahead. And finally, we have a discussion on prevention, where the bad outcome doesn't happen. And this is a number of things. One, it flips the narrative, shows you these things are preventable. And then also it allows us to start recording the value of prevention, because prevention, you can't really report or write case series on things that didn't happen, but with stories and how this is possible. In summary, we talk about what we know, what we want to do, and what we can do. And the whole event takes about 90 minutes. And again, it's timed when the community is ready to receive it, because that's when they want to show up and participate. Some of the things that resulted from this one event that we did in this community hospital in rural Massachusetts is that 90 people learned how to recognize that there was an increasing rate of suicide, and that they learned what protective factors were, what warning signs were, and what the risk factors were. They also began to see what their role is in preventing this. They also had some ideas about what's the best case scenario, what resources do we have, and with that, they had agency to go forth and do something on their own. And what happened was significant. And I'm saying this because I worked there, and so I know, and I learned from my colleagues. But within the following 2 weeks, a vascular surgeon met a patient who came in for a pre-op for a surgery. And when you are older and a veteran and you have a firearm, and your independence has been compromised, you're depressed. And this surgeon recognized that his patient was pretty depressed when he was scheduling him for a procedure, right? And so when you are medically ill, that's also a higher chance of you being suicidal or thinking about completing suicide. And he recognized that his patient was depressed, and he recognized that his daughter was worried about him. He asked his patient if he had firearms, which most physicians don't ask their patients that. And when when the patient said, yeah, I have guns, and he's a veteran. Well, he said, well, we should make sure that that gun gets out of the house. And this was not a hard conversation. And actually, at the end of it, it resulted in the family coming much closer together and making that patient safe, who then 2 weeks later came back and had a surgery. So this is a prevention narrative. And a surgeon, vascular surgeon who's not trained in injury prevention, started to practice something different. A nurse, an ER nurse, who learned about the different risk factors and the warning signs for suicide, recognized that a police officer who came in as the husband of a patient who did not survive her medical emergency was at risk. And so she reached out to his colleagues in law enforcement who were also there to make sure he was safe. And this is one of those things that she would never thought of doing, didn't understand why nurses need to ask or think about firearms among their patients. But doing so, she recognized that there was a risk here and did something different. We also identified there are a lot of silos. There are a lot of people working in the space of injury prevention that we may not know each other. And there was a nonprofit that we worked with at the event who I had never heard of after working there for 17, 18 years. But we found each other and they presented, and they have services for people who are at risk of suicide or whose families have experienced a suicide death and are able to connect them. And we actually had just had a case where someone who had witnessed a suicide then went on to die by suicide herself. And it was a friend of one of the nurses. And she said, oh my gosh, if I knew that resource existed, I would have referred you. So kind of at the end of this, realized there are a lot of these opportunities that exist in the community. There's no connections are being made. And so we can, through EMS and through ERs, we can start making those connections for those highest risk people, because that's where the highest risk people show up, emergency rooms. Another thing, there was a retired cop in the audience who had a radio show. And so what he did in his morning drive show the next 6 weeks is he had me and an ambulance driver and a paramedic talk about firearm suicide in our community. And every time there was another one, which there were more, he would have us come on the show and talk more about it. And this is one person who had a vehicle for change, which was his radio show. And he thought, I'm going to try putting it to good use. And so he started, and this began, I think, to, well, at least change social norms with him. This is an example of things that people will do when they know what they can do and they have the right messaging. Finally, we talked about at the event what works nationally, and there was a precedent for gun storage, safe gun storage in another state, Colorado, where if you're concerned about your spouse's or your own or your family members' firearms, you can turn them into a gun shop for safekeeping for that period of crisis. And because there is buy-in from the gun stakeholder group, this is a positive social norm. And so there was a gun shop owner that came to this event who said he wanted to do this himself. He wanted to recreate this in Berkshire County. So the point is that this is just what I know from living here and working here and doing this event. But what we're doing right now is that we are trying to evaluate, well, what is the impact that we can do empirically, prospectively with this? And the important thing is we're focusing on one audience, one unique community that is both clinical and non-clinical, so that everyone can see the entire arc of the problem and move upstream together. And what we're doing with these cases and with the education, workshopping, what can we be doing in the role that we have right now to actually make a change and work towards prevention? Because then we can also, with this group, we can bring in the expertise that exists in our medical networks. Pediatricians, emergency physicians, surgeons, we all have guidelines, we all have education for each other on how to better connect with our patients. This is an opportunity for us to deliver it in as easy way as possible, and it's relevant to that community. So next steps that we're doing is we're trying to make this education accessible. We're really good at talking to each other in healthcare. Our language is not always understood by people not in healthcare. And so how do we create education that's accessible to the general population? And so we are conducting a couple undergraduate curricula right now on violence prevention to evaluate, okay, what is most effective at messaging to the community and what can they tell us themselves, so we can incorporate this in our education moving forward. We would love to engage with as many people as possible in developing this curricula. And behind this is we're developing a resource archive and a community action group portal, so that these groups, when they convene, will be able to stay together and stay connected, and we'll be able to give resources for intimate partner violence, for suicide prevention, for targeted violence, et cetera, as they exist in communities, and to make it easy that people stay connected. Because the point here is to make this extensible. We want to be able to have groups supported, but also have new groups succeed after we intervene with them. We want it to be easy for them to opt in and opt out, right? So these people are going to show up when there is a crisis moment. They may not stay for the duration, but they can show up and give something of value. And it's a way for us to distribute the leadership, because people will identify, as I describe these nurses and this physician, and these people identify themselves as leaders in doing something. And how can we make it easy for them to participate and engage with us? Because ultimately, at the end of the day, there's sidelines. It's all front lines. And it would be good for all communities to be engaged with each other in identifying health-based solutions that each of us can start to practice, from law enforcement, from schools, from EMS, and so forth. And so the ways that we can continue to work together is to work with us in our community outreach. If you have communities that wish to engage in us and their health system, please contact us, and we can help to facilitate that. We're developing education and would love to incorporate what we know works. When I met this group not that long ago, I learned about some bystander interventions that are being performed in other countries that I think it's a great opportunity for us to show how they work here. And this is a way for us to amplify what's currently being done. And that's it. This is how you can contact us. And I welcome the opportunity to work with anyone in the pre-hospital setting, law enforcement, to move this ball down the field as quickly as possible.
Chris, this was just tremendous, just wonderful. Thank you so much. I just love the narrative, the approach to narratives. I just think that that's so impactful and hasn't been given enough space. Thank you so much. So much in here. We have about 5 minutes left. I welcome anyone to write something in the Q&A or speak. or raise their hand, and I will unmute you. Go ahead, Debbie.
Thank you, Jen. Dr. Barsotti, that was wonderful. I'm Debbie Plotnick. I'm with Mental Health America. And Mental Health America, we like to think of ourselves as Switzerland when it comes to gun control, completely neutral on the topic. However, I work closely with the Brady campaign and with folks who consider themselves members of the 2A community. And it's pretty remarkable for a person that's never owned a firearm. But what we talk about is ways to prevent violence, specifically suicide prevention. You hit on many of them. Because suicide is the second leading cause of death for young people in the United States, it's really important for people to understand and have education about keeping their firearms safe in their homes. So the way that I've learned to approach it by partnering with people who own firearms is to never say, do you have firearms in your home, but to assume they have firearms in their home and to say, how are you storing them? And that way nobody gets their dander up that I'm accusing them in any way. And if they don't, they say, hey, we don't. And if they do, then we can talk about this. And the flip side of this is people who need mental health help. They're depressed, they're overwhelmed, they're anxious, they're suffering from trauma, especially people who use firearms in their professions, especially important in this context, police officers and veterans and so forth, and that they're afraid to reach out for mental health help because of the fear of having their firearms taken away and perhaps ending their livelihoods, their careers, and so forth. So these are all pieces that fit into this. And I would love to work further with you to help bring some of these people and some of these concepts together.
Absolutely, I fully welcome that, because the education that we provided, and I can share that with you offline to the community, it was very practical education. It was why second chances matter, why most people attempt suicide who survive suicide will not attempt again. And learning how to speak about the brave conversation you have to have with your community about limiting lethal means in those moments. And I think that when we use the narratives, provided we cultivate them properly and don't get lost too much in the weeds, we can stay pretty problem focused and learn efficiently how we need to speak about it. And I told you the narrative, I gave a brief description of the narrative, the first narrative in our reframe. And it was a case where the friend, it came about because, let me say it differently. So when we, as a group, walked the cat back to the different points where things could have changed and this man would not have died by suicide, the audience, which was the community, recognized that the best chance for him was for his friend on the phone to talk to him about his gun. And because one, the friend is a trusted messenger, two, cares about him, and three, is the most likely person to have an impact. And that's the most upstream you can get from that crisis moment. So we can learn these things from each other. And I think we can, and the point is, how can we gather as much information and this knowledge as quickly as possible and disseminate it?
Exactly. If I can say one other thing, we partnering with the folks who own firearms so that the folks are not afraid to reach out and to say they need help. And Mental Health America has this screening site, internationally reached, mhanational.org/screening, and folks can come and take a free anonymous screen. And our partners in the firearm owning community use our screening through their links. People come to us that way, and that way people can take a checkup themselves. And then we can get into these kinds of conversations, because we want people to not be afraid to get help when they're feeling like they're not okay.
Right. And this is exactly how, and also there's messaging that we can add to it. One thing that's come new to our parlance is that it's okay not to be okay. Right. Exactly. And so the more, and we learn this from our communities and from our peers. So, and this is how we change social norms.
Wow, again, this was incredible. Talk about a mind shift and a reframe. I mean, I'm just taking all of this in, and I feel like what's come out of this is a wonderful new connection with you and Debbie, and hopefully others on the panel that you may or may not know. Please take the opportunity to ping each other on Whova or through me, because I know both of you. Thank you so much, Chris, and thank you all for being here. And I hope you enjoy the rest of the conference.
Thank you.
Thank you, Jen.
Thank you. Great to see you.
Yeah, great to see you. Thank you so much.
We'll talk soon. Bye.
Bye.